Hi, good afternoon. First of all, I would like to thank Allergan and, of course, all the people from the Will side. And Dr. Paranios, he did part of my job because I have to talk about stereo disc photograph. All we know that with improvements in quantitative imaging technologies, such as HRT, OCT, GDX, the question today is, do we still need to obtain optic disc photographs to evaluate progression or for baseline examination in our glaucoma patients? And in my opinion, the answer is yes, because although these new technologies provide important quantitative information about the optic disc and about the nerve fiber layer, personally, I think that this new data supplement rather than replace the stereo disc photograph. As we know, until now, stereo disc photography, preferably with simultaneous acquisition, still remains the standard of care for recording the appearance of the optic disc in glaucoma patients and suspects. As Dr. Paranos told us before, optic disc photos should be obtained on virtually all glaucoma patients and suspects, especially at the baseline examination, for several reasons. But here we have some of them. First of all, they provide a permanent record of the appearance of the optic nerve that doesn't depend on specialized viewing equipments. Definitely, photographic images more closely reproduce the actual appearance of the optic nerve as compared with any of the pseudo-color images provided by the quantitative imaging technologies. They may also aid in making the initial diagnosis by enhancing the clinical examination. And finally, definitely, photographs provide a baseline documentation to which subsequent examinations can be compared for detection of change over the long run. There are several methods for registering or recording the appearance of the optic disc. And we have to say something. Always, the optic nerve appearance should be registered during the clinical examination. But in some places where other methods do not exist, to draw in the optic disc is the only tool we have, and is very well recognized for all glaucoma societies. If we had the chance to take pictures, definitely we have to say that stereoscopic evaluation of the optic disc is more reliable than monoscopic evaluation in terms of best or larger estimates of cap-to-disc ratio under stereoscopic conditions. On the other hand, we have to know that stereo disc photos can be obtained simultaneous or sequentially, and most studies recommend simultaneous stereophotograph because they have afforded the best stereoscopic effect and the best reproducibility. And finally, stereo disc photograph can be captured either on color slide film or digitally, and this last form has some advantages related with the first one, but especially they have the possibility to rapidly alternate between images at high magnification to assess progression. As I told before, photographs may improve the clinical examination because they provide stereoscopic images that can be analyzed or observed during extended periods of time, allowing for the discrimination of more subtle details. For example, in the OATS, review of stereo disc photos was more sensitive for detecting optic nerve hemorrhages than clinical examination. if we see the second point, only 16% of these hemorrhages were detected on both clinical and photo evaluation in this study, whereas 84% were detected on review of stereo disc photos but missed on clinical examination. So, about the question. Unlike a stereo disc photograph, there is no guarantee that the imaging technologies will be forward compatible. All we know that technologies become obsolete at an increasing rate, especially as newer and better instruments are developed. So, the question is, if we use only quantitative imaging devices, first of all, will the baseline image taken with today's quantitative machines be compatible with a newer platform in the future? Or even if the older images can be successfully imported into the new platform, will the critical features that we are measured today still be relevant for assessing progression in the future? Many investigators have assessed this issue, and they have compared the diagnostic ability between imaging devices and the qualitative evaluation of stereo disc photos. In this paper of Dr. Besani, for example, they found, or this group found, that Stratus OCT HRT3 and GDX perform better than subjective assessment of the optic disc photos, but by a general ophthalmologist, but not by a glaucoma expert. In this paper of the group of Caprioli, they found almost the same. They found that the diagnostic ability of Stratus OCT, GDX, and HRT3 perform as well as, but not better than, the qualitative evaluation of optic disc photos, especially for the detection of early perimetric glaucoma. And finally, I would like to show you this paper where the investigator compare the nerve fiber layer thickness measurements between two versions of the same instrument, that is an OCT. And they found that even using a correction factor, the agreement between the two instruments was low. So if this problem was illustrated here, the question is, what will happen when entirely new technologies replacing the existing ones? Until now, I'm not against the new technologies, but I think that meanwhile they are improving their ability, their reproducibility, what we know now is this, that stereo disc photographs can be obtained with the assurance that in many years the data encoded in them will be accessible and still relevant for comparison and to evaluate progression. It's published everywhere, and in the last consensus of glaucoma progression, the World Glaucoma Association said that color fundus photography is the preferred imaging modality to identify disc hemorrhages and parapapillary atrophy. And as conclusion, I would say that still today, serial optic disc stereophotographies are valuable and enduring methods for monitoring structural progression. Thanks.
I have to agree with a lot that you said, largely because I've watched platforms come and go. I've been in practice here at Wills for 29 years now, and the Stratus that we all started with was never replaced. So all the data we had on the original Stratus OCT was replaced by the Cirrus OCT, and all of a sudden we had to get new baselines on every single patient, which is particularly annoying when we follow these patients carefully. However, that being said, and I agree completely about stereo disc photos because I have had our disc photos scanned in and our computer systems have come and go, but the pictures remain. And no matter what, we have the original photos. And what I find very helpful is when I see a patient originally, we print out an extra digital copy of their photos. Why? Because they travel. Travel today is nothing. They start in Philadelphia, they wind up in California, and then they go abroad. But their optic nerve pictures always stay the same, at least at baseline. So because glaucoma is a disease of change over time, I think that's very, very valuable. However, if just to play the devil's advocate now, we all agree that structure changes before function. However, I'm not sure, and I've been looking at optic nerves a long time, that I can always tell when something is changing. Jack, can I have the slides? My slides. I just want to pick out something to show you. And what I find very, very helpful now is using the OCT in addition to what we have to really help us decide progression in the beginning. Everyone here in this room understands that when the visual field gets worse, we don't need $55,000 machines to tell us this patient's getting worse. That doesn't help anybody here, especially in this financial climate. Jack, can you go where they're all on one so I can pick what I want? Yeah, like all, yeah. Give me 1 second here. You know what? I'll just show this. Let's just start right here. Thank you. I just want to show you on the flip side how I use the OCT to help me early on, and that the photos are just another piece of the puzzle. So here we have the spectralis. This is the Heidelberg OCT, and everyone in this room knows that the defect occurs along the superior and inferior arcades, and what we're looking at is the circle scan around the optic nerve, and it's normal. But now we're being able to look at the macula scans, which is so much more sensitive and tells me early on when someone is getting worse. So what I'm looking for here is a darkness in this area between the ganglion cells, the nerve fiber layer complex, and the outer plexiform layer, because we now know that glaucoma is pathologically determined by death of the ganglion cells, and this shows up early in the macula. So what am I looking for now? We know that there's a nerve fiber layer defect. It shows up on the circle scan in red. Everyone can see that. Here is the visual field loss, and here is the macular zone. And this is very advanced. No, that is consistent with advanced disease. But look at this. This is what really helps me with the new technology. Here's the optic nerve. Look at this small nerve fiber layer defect. The circle scan is still normal. It doesn't pick it up. But notice here, in looking at the macular vulnerability area, they're starting to show some absence of color or blue. And when you follow this patient, the circle scan is still normal. The pressure now is still uncontrolled. The visual field is still normal. But notice here how this area is starting to get dark. There's less tissue. The nerve fiber layer ganglion cell are moving south, and they're not doing well. Now, we all know that when we show progression here, we could see that in the circle scan, but it is so nice to be able to see it in the macular zone, where this patient has a pressure of 23, and on the bottom, still 23, not well controlled, and over a year's time is slowly getting worse. So it's clear that when you have very progressive disease like over here, nobody needs an OCT to tell us what's going on. But look in the normal, this is a normal, almost normal visual field. Look how the OCT helps me decide whether to treat this patient. Here on the top, notice how healthy and colorful it is. But in the inferior zone, notice how dark this is. They were losing ganglion cells here. And in the eye that had terrible glaucoma, there's very much darkness here. When I compare the normal visual field eye to the advanced, this is still normal. This is pretty advanced. And here you could tell, comparing the superior hemifield to the inferior, this is where the damage is. And this is where the patient needs to be treated. So for me, this is very new and exciting technology. Why? Because we can figure out beforehand which eyes will develop real loss, or in other words, catching the horse before it gets out of the barn. And that is why I like using the new technology, not in isolation, but with the company it keeps, because I want to know early who's going to develop field loss. I don't want to watch it happen. So that's really what I have to say.
I would like to ask you the same question someone asked me this morning. Would you feel today in your practice comfortable with an OCT change, isolated, and all the other exams normal? Would you change the way you treat the patient?
Absolutely not. No. I think that one has to, the reason these machines are never going to replace us is because we have the brain to put it all together. So when something doesn't make sense to me, I do not include it in the whole picture. So if everything else, if the clinical exam is normal, they have a small little cup and they're not a hyperope, so there's no abnormality there. And their visual field is normal. And their pressure is 22, but their corneas are 580. You know, these people don't have glaucoma if their pressure is 17 or even if their pressure is 27, unless, of course, they have other risk factors. So if the OCT is a little abnormal, I won't buy that totally. But what I will do is repeat the OCT in 6 months to a year. Assuming good registration, if there is progression, I will really pay attention then. So if you can trust your OCT to line up the optic nerve exactly, if there is a 3, 4, 5 micron loss over a period of 6 to 12 months, that's a big deal. And I would then start paying very close attention. Because normally as we age, we only lose 0.1 microns of nerve fiber layer per year. So not 5. And therefore it makes sense to pay attention, but not base your treatment totally on one isolated incident. Does that make sense to you? Do you agree?
The only point that I'm concerned sometimes is about the resolution of the machine, because the machine has a 10 micron resolution. We cannot consider a 5 micron change as a real change. But I totally agree with your thoughts.
I think it also depends on which OCT you use. With the Spectralis that I have the most experience with, that's the Heidelberg, there is easily a 2 micron resolution that's acceptable. And after that, I really start paying attention. Not 10. 10 would be horrendous for us. Yeah.
I would like to point out only a single thing. I totally agree with what has been said. But there's a difference between the HRT and the OCT, and it's that, among other differences, of course, is that the HRT engineers have seemingly taken care of making compatible all the different versions of the device in order to compare the different stages of the disease among the different models of the devices being developed.
That's true, but Daniel, tell me something. How do you then put this into your clinical treatment of the patients? Where do you feel that this technology fits in with your scheme of things? You've been in practice a long time. You've seen gazillions of patients. When do you say, okay, this is real, and when do you just say it's not? How do you know?
I must admit that, for example, in the HRT, which I use, it's highly dependable on the operator, and many differences found between examinations are mostly differences in how the images were taken, and the baseline differs, and you cannot really compare. But one other thing that I may say is that using HRT and OCT allows to know exactly the size of the optic nerve disc, which is highly dependable otherwise and subjectively.
Thank you.
My point about the OCT, I think both points are good, and the compatibility issue is important, and that's one that is frustrating. I mean, you lose a lot of data. But looking back at this a little bit, I think there's one more thing that I do that I'm sure a lot of you also do, and I sort of alluded to it in an earlier talk, and that's actually just drawing the nerve. And I think as much as the pictures are useful, sometimes the image quality is not that great. They're cataractous. The patients are poorly compliant. I think sometimes drawing the disc, that first impression, that first visit I get for them, sort of puts the patient's disease in some kind of perspective. And then going forward, my preference personally is to I follow a little closer with the OCT. So I like to do an initial disc drawing, get a sense of where I feel that patient's risk is with all the other things, and then I follow my patients with the OCT. And I frankly believe the spectral domain OCT is a big advance. And I agree that the resolution is better than 10. It's more like less than 5 microns. So generally it's pretty good. Again, image quality is important.
But Michael, when you draw your optic nerves, do you find that if you're having a good day, the cup looks pretty small, and if you had a fight with your wife, the cup is quite big? And then when you sometimes compare, I remember in our old charts before we went to the computer, we had these thick charts, and I'd look at our drawings of the optic nerve, and sometimes they're small, and then they got big, and then they got small again. So what do you think about that?
I don't think it's necessarily the best way to follow the disc. You're right. And I don't always believe my own drawing if I think things have necessarily progressed. I like to put everything together. But I'm talking about my initial impression where I really do pay, at least I try to pay as best attention as I can to that disc, that first visit, that first consultation.
Great.
I just had a comment regarding the HRT device. Augusto Praños showed a very useful technique in comparing photographs, which is flickering. And you can use that function with the HRT if you have the screen on it, not on the printout. And I find it useful, especially when you have a focal light defect, that you can document with the HRT, and you can use flicker with that, and you can find out easier if there is a progression.
How many people here use the flicker technique for looking at optic discs? Few. Very good. Thank you. That's a very good comment.